I'd like to thank Dr. Faltered for inviting me to speak today on normal variants and lesions of the central skull base. I have nothing to disclose, but I would like to acknowledge that case material has been contributed by Drs. Dvorak, Agarwal, and Dr. Rothfuss. Both Dr. Agarwal and Dr. Rothfuss are at the University of Pittsburgh. In the next 30 minutes, we will review the central skull base anatomy and define the importance of CT and MRI in assessing central skull base lesions, and do a case-based review of lesions centered within the skull base. The skull base can be divided into the anterior skull base, the central skull base, and the posterior skull base. Today we will focus on the central skull base, the primary component of which is the sphenoid bone, which has been outlined here in red, and there is a smaller contribution made by the basal occiput. The sphenoid bone consists of the lesser wing, which includes the anterior clinoid processes, the greater wing of the sphenoid, which includes foramen ovale and spinosum, and the body of the sphenoid, which helps to form the floor of the sella turcica and houses the sphenoid sinuses. The central skull base can be well imaged with CT, particularly its bony anatomy. This is a 3D volume rendered shaded surface display reconstruction of the skull base. And again, we can nicely see the anterior clinoid process, which is part of the lesser sphenoid wing. Directly medial to it is the optic canal. We can see portions of the greater sphenoid wing bordering the middle cranial fossa, as well as foramen ovale and spinosum, paralleling foramen lacerum. We can see the dorsal margin of the sella turcica with the posterior clinoid process. Remember that the superior orbital fissure is formed as a cleft between the greater and lesser wing. So here's the lesser wing and the greater wing of the sphenoid sinus, and we can see this thin cleft, which represents a superior orbital fissure, and it allows communication between the orbit and the intracranial compartment. Numerous cranial nerves pass through the superior orbital fissure. As a result, processes affecting the central skull base are oftentimes associated with cranial neuropathies. This is a view looking through the orbit where we can again see the cleft of the superior orbital fissure, which is a cleft formed between the greater and lesser sphenoid wings. This can be imaged in the axial plane. So let's remember the anterior clinoid process is part of the lesser wing of the sphenoid. It can also be seen here in the coronal plane, and just medial to it is the optic canal. As we extend caudally, we can see this short segment discontinuity between the lesser wing and greater wing of the sphenoid, which represents the superior orbital fissure. This can also be seen in the coronal plane. The yellow arrows point to the superior orbital fissure in the axial plane, which then extends to the orbital apex. Just lateral to the body of the sphenoid, we can see the rounded foramen rotundum nicely in the coronal plane. Note that in the axial plane, it appears as a tubular structure extending in an anterior to posterior direction. Just caudal to the foramen rotundum, seen here on the next slide, is the Vidian canal, also running in an anterior to posterior direction in the axial plane. It also appears as a rounded foramen along the inferior margin of the sphenoid sinus and body of the sphenoid as viewed in the coronal plane. The Vidian canal extends from foramen lacerum anteriorly toward the pterygopalatine fossa. The yellow arrows point to the Vidian canal, and the red circles indicate the location of the pterygopalatine fossa. Directly Parallel to the irregularly shaped foramen lacerum is the foot plate of the skull base, referred to including foramen ovale and foramen spinosum. Note that foramen ovale does have an oval-shaped configuration, and foramen spinosum has a small rounded configuration. These directly parallel the irregularly shaped foramen lacerum, which contains cartilage. Foramen ovale and spinosum together are often referred to as the footprint of the skull base. In the coronal plane, note that foramen ovale appears as a short segment discontinuity along the floor of the middle cranial fossa. By definition, foramen ovale and spinosum are located within the greater sphenoid wing. Foramen ovale allows V3 to traverse it from the intracranial compartment, extending into the masticator space. Let's review that anatomy. The green arrows are pointing to the anterior clinoid process, which by definition is part of the lesser sphenoid wing. Just medial to them is the optic canals containing the optic nerves indicated by the red circles. The anterior clinoid process connects to the body of the sphenoid via the optic strut. The V of the vomer points to the Vidian's canal, which runs along the inferior margin of the body of the sphenoid, just inferior to the sphenoid sinus. Directly superolateral to it is the rounded foramen rotundum, which contains V2. The Vidian's canal and foramen rotundum lie directly superior to the pterygoid process, which is part of the sphenoid, and the lateral and medial plates of the pterygoid extend caudally from the pterygoid process. MRI is helpful for characterizing the surrounding intracranial compartment and the relationship of the sphenoid to the surrounding brain and overlying critical neurovascular structures. The anterior clinoid process with its fatty marrow can be well imaged with MRI and can serve as a landmark to help locate the optic nerve, which sits directly medial to the anterior clinoid processes. Note also that the adenohypophysis lies directly superior to the body of the sphenoid, and that the cavernous internal carotid artery also lies superolateral to the body of the sphenoid. As a result, processes affecting the central skull base can affect the cavernous sinus, the multiple cranial nerves housed within the cavernous sinus, and the internal carotid arteries. Large central skull base processes can cause mass effect on the optic chiasm or affect the adenohypophysis. In the coronal plane, V3, as it exits the skull base via foramen ovale, is also nicely imaged and normally has a surrounding enhancing venous plexus that we see here. This is a reminder that foramen ovale appears as a short segment discontinuity in the floor of the middle cranial fossa. Directly posterior to the body of the sphenoid is the pons and the root exit point of the cisternal fifth nerve, which then extends toward the Meckel's cave, seen as the CSF space directly lateral to the body of the sphenoid. This is an image demonstrating that the cavernous internal carotid artery and the cavernous sinus lies directly lateral to the body of the sphenoid, and the cavernous sinus houses multiple cranial nerves, including cranial nerves 3, 4, V1, V2, and centrally cranial nerve 6. It's important to note that understanding sellar development as well as development of the clivus is important, as there are many normal variants that occur within the central skull base related to its embryology. At 3 to 4 weeks, the stomadeum and diencephalon combine to form the neuroectodermal adherence indicated by the blue asterisk. The neuroectodermal adherence then undergoes dorsal migration at approximately 4 to 5 weeks and forms the Rathke's pouch indicated by the purple asterisk. At approximately 6 to 7 weeks, there is approximation of the postsphenoid cartilage, and this causes resorption of the adenohypophyseal stalk. Normally, the Rathke's pouch will obliterate. If there is incomplete resorption of the adenohypophyseal stalk, this can result in a variant within the skull base referred to as the patent craniopharyngeal canal, which would extend from the floor of the sella to the anterior margin of the clivus, as indicated by the red dotted line in the diagram. It's also important to understand the development of the clivus. The clivus has two components to it. Anteriorly, the basisphenoid, and posteriorly, the basiocciput. The spheno-occipital synchondrosis, indicated by the green arrow, is normally present, contains cartilage, and allows for growth of the central skull base. It typically fuses by 17 to 18 years. The notochord is the primitive skeleton and contributes to the development of the intervertebral discs. Its normal course is indicated here by the yellow line. Note that it takes a sigmoid course through the clivus, and it reaches the surface of the bone at the posterior clivus, as well as along the ventral margin of the clivus where it extends to the pharyngeal surface, and again along the dorsal superior margin of the clivus in the region of the dorsum sellae. It's important to be aware of this sigmoid course of the notochord through the clivus, as there are numerous lesions that occur along this course, both normal variants as well as pathologic lesions. The red line shown here demonstrates the expected course of the craniopharyngeal canal, which can be present when there's incomplete obliteration of the adenohypophyseal stalk. The last point to note about the clivus and skull base is to remember that the skull base forms from enchondral bone formation, in which a cartilaginous framework is replaced with bone. Now that we've reviewed the anatomy and development of the skull base, let's look at some cases. First, we'll focus on lesions centered within the bone of the skull base, primarily consisting of lesions centered within the sphenoid, particularly within its midline. So this is the first case, and what we see is an area of rounded, decreased attenuation in the body of the sphenoid. Note that it follows fat attenuation and has relatively sclerotic borders, but is not expansile. Again, when we look in the coronal plane, we can see this area of fat attenuation and the left aspect of the body, the sphenoid, with relatively sclerotic margins. When we look at this area on MRI, we can see that it is T1 hyperintense and is isointense to other areas of fatty marrow, that it loses signal on a T2 fat-saturated sequence and does not enhance. And this just represents an area of arrested pneumatization or variation in the marrow pattern within the central skull base. And this is a benign finding for which no intervention is required. It's important to recognize this because it is quite common. Here is another example of arrested pneumatization. Note that the area consists of T1 hyperintense fat signal on this T1 weighted sequence, and on the CT, it appears well-defined, non-expansile with sclerotic borders. Again, a second example of arrested pneumatization or medullary variation within the skull base, and very common within the body of the sphenoid. It's important to recognize as no intervention is required. These are seen commonly because the appearance of the sphenoid varies over time. At birth and during infancy, the sphenoid consists of red marrow. Over the course of time, with age, the red marrow is replaced by fatty marrow prior to pneumatization of the sphenoid sinus. When the process is disrupted, areas of reduced pneumatization can occur within the skull base. The sphenoid sinus itself begins to develop by age 2 years and has typically achieved adult size by 14 years. Moving on to the next case, this is a 56-year-old who was imaged for a cleft palate repair. And here we can see there is this bony discontinuity along the floor of the sella turcica, extending to the anterior inferior margin of the clivus, indicated by the blue asterisk. We can see it here in the axial plane as well. On the contrast-enhanced portion of the CT, we can see that the adenohypophysis, indicated by the red asterisk, extends into this bony defect, and this is a nice example of a patent craniopharyngeal canal. There are 3 different types, and this would fall into the medium type 2, containing some ectopic adenohypophysis extending into the defect. This is another patient, 62-year-old female with a history of ocular migraines. And notice that we see a normal appearing adenohypophysis, but just caudal to this, we see a mass with very similar enhancement pattern as the adenohypophysis centered within the sphenoid. Note the short segment and bony discontinuity along the floor of the sella posteriorly, which is thought to represent a small remnant of the craniopharyngeal canal. And this is an example of an ectopic pituitary adenoma. These can occur and are most commonly seen within the sphenoid sinus and nasopharynx. Remember, as the adenohypophysis develops, the neuroectodermal adherence makes a dorsal migration and forms the Raschke's pouch, extending through the post-sphenoid cartilage. If there is incomplete obliteration of the adenohypophyseal stalk, you can have a patent craniopharyngeal canal, but because of this migration pattern, you can also have lesions related to the adenohypophysis occurring along the expected course of the craniopharyngeal canal, as we see here. Here is another patient with nasal stuffiness, and note that we have a mass with relatively sclerotic borders centered within the basisphenoid. But note that on the contrast-enhanced MRI, the lesion enhances and does not follow fat signal. So this cannot represent arrested pneumatization. And this is an example of a surgically proven ectopic pituitary adenoma. This lesion was entirely intraclival with surrounding smooth bony remodeling. And no clear connection was seen between this lesion and the sella turcica. Now we'll move on to lesions related to the notochord, including the following listed below. This is a 48-year-old male hemophiliac who had presented with syncope and head trauma and had a head CT that did not show any acute intracranial abnormality. However, the patient was noted to have this small area of well-marginated sclerotic remodeling along the dorsal margin of the clivus with a small bony protuberance. Note that on MRI, this area has T2 hyperintense signal and does not demonstrate enhancement. And this is an example of E. chordosis physolifera, which is a benign hamartomatous lesion arising from ectopic notochord remnant. These are typically located along the dorsal margin of the clivus, are non-enhancing and most often intradural. You may see a small osseous stalk contiguous with the dorsal margin of the clivus, as we see here. The differential diagnosis primarily includes chordoma, though this is usually extradural, enhances, and usually has bony destruction associated with it. So this is just a diagram reminding us of this sigmoid course of the notochord extending through the clivus. And so you can have this benign hamartomatous lesion typically seen along the dorsal margin of the clivus associated with echordosis physolifera. Moving on to this 39-year-old who presented with a 6th nerve palsy, we can see here that there is a lytic lesion along the dorsal superior margin of the clivus extending to involve the dorsum sellae. On MRI, we can see that this area is T1 intermediate in signal characteristics on this T1 non-contrast image. On the two lower images, we can see that the mass demonstrates solid enhancement and has very bright T2 hyperintense signal characteristics. In this case, it's causing mass effect on the pons. And this is a classic example of a clival chordoma. Chordoma is typically T2 hyperintense, erodes bone, and oftentimes solidly enhances. In this case, the 6th nerve palsy is because of the erosion of the clivus as the 6th nerve travels through the clivus in Dorello's canal. Here is a companion case in a pediatric patient in which we can see, again, this T2 hyperintense mass centered within the clivus, causing mass effect on the pons and demonstrating heterogeneous enhancement with areas of solid enhancement as well as cystic non-enhancement. On the CT, we can see characteristic erosion and foreshortening of the inferior margin of the clivus, as well as erosion of portions of the jugular tubercle. This is a companion case of a 47-year-old male with dysphagia, and again, we can see that we have a relatively T2 hyperintense heterogeneously enhancing mass that does involve part of the clivus, but note that the majority of this mass is actually inferior and anterior to the skull base, protruding into the nasopharynx. The differential for this mass does include nasopharyngeal carcinoma, but this is a surgically proven chordoma with primarily subclival extension. Remember, when the notochord takes this sigmoid course through the clivus, it extends to the margin with the pharynx along the anterior inferior margin of the clivus. As a result, chordomas arising from the notochord path in this region can have a primarily subclival pattern of spread, as we see in this case. This was a 41-year-old female complaining of headaches, and here on the T1 weighted image, we can see there's abnormal T1 hypointense signal within the dorsal superior margin of the clivus, which is T2 hyperintense and does not demonstrate enhancement. And while one might consider the possibility of echordosis, when we look at the CT, we can see that there's actually sclerotic appearance to this lesion, which would not be typical for echordosis. And so this is a nice example of surgically proven benign notochord cell tumor. These tend to be intraosseous, T2 hyperintense, and non-enhancing, but have sclerotic bony changes without destruction, as we see in this example. These are relatively uncommon lesions. In this 52-year-old male with a history of trauma, we can see this well-marginated notch-like defect along the anterior inferior margin of the clivus with sclerotic borders. And this is a normal variant referred to as the fossa navicularis magna. It is related to the notochord remnant that prevents ossification and can contain lymphoid tissue or a torn walled cyst. MRI can better depict the presence of benign tissue associated with this lesion. So as the notochord extends toward the pharyngeal surface, this can result in incomplete ossification along the anterior inferior margin of the clivus, leading to this characteristic appearance of the fossa navicularis magna. In this 43-year-old male with a history of melanoma, we can see that there is a small T2 hyperintense cystic lesion with a notch-like defect associated with it along the anterior inferior margin of the clivus, and that the cyst does not enhance. And this is a nice example of a Tornwald cyst with an associated fossa navicularis magna. A Tornwald cyst is a cyst related to notochord remnant. A small diverticulum can form when the notochord and endoderm of the pharynx contact. As they regress dorsally, this can result in the formation of a small Tornwald cyst, which is mucosal lined. So as the notochord regresses dorsally, it can result in a small diverticulum, leading to formation of a small mucosal lined Tornwald cyst, for which no intervention is required, and these lesions will be frequently seen. They're always in the midline. They may be associated with this notch-like deformity along the clivus, and they can be quite large at times. This is a 24-year-old female who presented with headaches, and on this MRI that was performed, there's T1 hypointense signal seen within the clivus, lower than expected for the patient's age, and when compared to the upper cervical marrow. On the T2 and T1 post-contrast images, we can see there's a relatively expansile appearance to the clivus, and that it abnormally enhances. The CT here is particularly important because on the CT, we can see while the clivus appears somewhat expanded, we have this uniform ground glass appearance to the clivus, and that the process extends into the posterior skull base, and this is an example of classic fibrous dysplasia. This highlights the importance of using both MRI and CT to characterize skull base lesions. Sometimes lesions within the skull base will appear worrisome or aggressive on MR, and when you do the CT, you can come to a concrete conclusion about whether the lesion is benign or malignant. This is particularly important with fibrous dysplasia because it does contain abnormal fibrous tissue interspersed with normal or immature bone, and for that reason, because of this fibrous tissue interspersed, you can have heterogeneous enhancement patterns that can look worrisome on MRI. So if you have a skull-based lesion, we always recommend correlating both MRI and CT. In this 83-year-old female with altered mental status, we can also see this relatively sclerotic appearance to the sphenoid and the central skull base. When we look elsewhere in the calvarium, we can see that there's marked thickening of the diploic space, which is expanded and has this cotton wool type of appearance, and this is a classic example of Paget's disease, which has a coarsened trabecular pattern and is related to abnormal bone remodeling. The polyostotic form is more common than monoostotic, and it can involve multiple bones, including the calvarium. And this 80-year-old male who presented with cough and rhinorrhea, which was persistent, the patient underwent CT, and here we can see, again, lesions centered within the sphenoid and clivus, which has areas of bone destruction as well as stippled calcifications within the mass. We can see that it's relatively T2 hyperintense and heterogeneously enhances, and this is an example of a classic chondrosarcoma. They're oftentimes T2 hyperintense, may have areas of calcification. This one happens to be centered within the central skull base, but these can also occur off midline involving the petrooccipital synchondrosis, where there is normal cartilage seen normally within the synchondrosis and extending to foramen lacerum. This is a companion case, also a proven chondrosarcoma, and in this case we can see that the mass is T2 hyperintense, solidly enhances, and in this case is centered involving the petrooccipital synchondrosis and extends to involve foramen lacerum. And this 52-year-old male complaining of headache with fever following an adenoid biopsy, we can see that there's abnormal T1 hypointense signal within the clivus, edema seen on the T2 weighted sequence with associated abnormal enhancement. Note directly adjacent to the clivus, we can also see edema within the prevertebral space, as well as enhancement and soft tissue thickening. This patient had positive blood cultures, and this was osteomyelitis of the central skull base. Upon further questioning, the patient had indicated that following his recent biopsy of the adenoids, he had used cocaine, and this was felt to be a complication of the use of cocaine with an opened wound in the nasopharynx. So a nice example of central skull base osteomyelitis. You can also see osteomyelitis in the central skull base complicating malignant otitis externa. And the 70-year-old male who presented with pressure behind his left eye and reduced extraocular movements, we can see a large lytic lesion involving the left greater sphenoid wing and extending to involve the sphenoid sinus. On MRI, the lesion was noted to be relatively T2 hypointense, solidly enhanced, as we can see here, and on diffusion weighted maps had relatively low ADC values. Additional, much smaller lesions were seen, and as a result, it was suggested this could represent multiple myeloma or metastasis. In this case, this is confirmed multiple myeloma. Now we're going to move on to lesions centered within the sphenoid sinus. This is a 26-year-old who presented with nasal congestion, and here we can see that there is increased attenuation within the sphenoid sinus, which is expanded and extends into the sphenoethmoidal recess with areas of partial mineralization. Again, note in the coronal plane that the sphenoid has some expansion and some areas of osseous remodeling along the margins of foramen rotundum and the Vidian canal. On MRI, the contents within the sphenoid were markedly T2 hypointense and T1 hypointense with just a small periphery of enhancing mucosa within the sphenoid. This is also appreciated in the coronal plane, and this is a classic example of allergic fungal sinusitis, which consists of chronic polypoid rhinosinusitis. The contents within the sphenoid represent mucin and non-invasive fungal hyphae. This occurs in immunocompetent patients and can lead to areas of mucocele formation with obstruction of the sinus. In this immunocompromised patient, again, we see opacification of the sphenoid sinus as well as posterior ethmoid air cells. But note in this case that the lateral and posterior walls of the sphenoid have been eroded. Similarly, there is early erosion of portions of the adjacent greater sphenoid wing. On the soft tissue windows, we can see there's infiltration of the left orbital apex and abnormal soft tissue in the superior orbital fissure. Note also that the ipsilateral cavernous left ICA is markedly small in caliber compared to the normal right side, indicating an aggressive process. And on MRI, we can see that there's actually abnormal enhancement of the wall of the ipsilateral cavernous left ICA, as well as inflammatory changes in the left orbital apex. In the coronal plane, the abnormal enhancement of the cavernous left ICA is seen, as well as abnormal enhancement extending into the left superior orbital fissure and left orbital apex. And in this immunocompromised patient, this is an example of invasive fungal sinusitis characterized by areas of soft tissue infiltration, bone erosion, and loss of contrast enhancement within nasal and paranasal sinus mucosa. You can have intracranial and intraorbital extension, as you see in this case. You can also have associated hemorrhagic infarcts, arterial and venous occlusion, and areas of pseudoaneurysm formation. And this is just a reminder that the central skull base is bordered by the cavernous internal carotid arteries, and so when you have an aggressive process affecting the sphenoid or central skull base, this can lead to neurovascular complications, so it's important to always look for this. And the 65-year-old female with a history of persistent rhinorrhea, we can see that there is opacification of the lateral recess of the right sphenoid sinus. Note that there is a short segment bony discontinuity along the superior margin of the lateral recess of the sphenoid. And on the MRI, we can see that the ipsilateral right temporal lobe protrudes through this defect. So this is a nice example of an encephalocele. Very important to remember when you have isolated opacification in the sphenoid sinus, you should always ask yourself whether this could be an encephalocele, particularly along the lateral recess, as this is a common location for encephaloceles where the wall of the sphenoid is relatively thin and weak. On the contralateral left greater sphenoid wing in this patient, we can also see areas of pitting of the skull base with arachnoid granulations extending into these areas on the MRI. Sometimes these features can also be seen in patients with pseudotumor cerebri, but it is not required. This is a companion case of a 66-year-old female with fever and altered mental status, and this isolated opacification of the right sphenoid sinus was interpreted as inflammatory opacification on the head CT, but note that the adjacent sulcus ipsilateral to the sphenoid sinus opacification is widened. I refer to this as the widened sulcus sign, and this can be an indicator that, in fact, what you're seeing represents a meningoencephalocele rather than inflammatory opacification. On the MRI, again, we can see the ipsilateral widened sulcus, and the coronal image confirms that this represents part of the right temporal lobe and surrounding subarachnoid space extending into the right sphenoid sinus. Unfortunately, this patient had meningitis as a complication, and we can see pus and debris restricting diffusion within the left temporal horn and occipital horn. And the surgical planning CT nicely demonstrates the bony defect along the lateral wall of the right sphenoid sinus. That defect is hard to appreciate on the MRI, and again, this emphasizes the importance and complementary effects of using CT and MRI to characterize central skull base lesions. So a nice example of a meningoencephalocele with meningitis. In this 62-year-old who presented with new visual field deficits, we can see in this case there is a large mass centered within the sphenoid sinus with extensive bony erosive changes resulting in intracranial extension, complete obliteration of the adenohypophysis and of the overlying optic chiasm. We can see there's marked mass effect with vasogenic edema involving the overlying brain parenchyma. This ended up being squamous cell carcinoma, although it could have very easily been sinonasal undifferentiated carcinoma or possibly a large B-cell lymphoma. Primary sphenoid sinus tumors are relatively uncommon, but when present are oftentimes associated with cranial neuropathies given the numerous adjacent skull base foramina traversing the central skull base. Now we'll move on to the last category of lesions associated with the central skull base, which includes lesions arising within the overlying intracranial compartment or directly inferior to the skull base and secondarily involving the sphenoid. So this is a 46-year-old female who presented with headache and vision changes, and here we can see a large extraaxial, avidly enhancing, partially mineralized mass along the planum sphenoidale of the sphenoid. We can see that there's ipsilateral expansion of the right aspect of the sphenoid sinus, as well as overlying hyperostosis. And this is a nice example of a meningioma with associated pneumosinus dilatans, referring to this increased pneumatization or expansion of the sphenoid sinus, and has associated hyperostosis, a common finding seen associated with meningiomas. The MRI nicely demonstrates the relationship of the tumor to the optic canals, which it extends into, as well as the relationship to the brain parenchyma with associated vasogenic edema seen in the anterior right frontal lobe. Here's another example of a meningioma, and the first row we can see that there's an avidly enhancing mass along the left greater sphenoid wing and involving the cavernous sinus, referred to as a sphenocavernous meningioma. In this case, there's extension into the left superior orbital fissure as well. And on the postoperative study, the patient has undergone resection of the left lateral orbital wall with a fat graft in place and debulking of the tumor. I show you this because I think it's hard off of these set of images to really understand how much the orbital apex has been decompressed. But again, if you look at the CT, it becomes much easier to see that the entire left lateral orbital wall has been resected, and this 3D reformat gives a better sense of how much the left orbital apex has been opened up following resection of the left greater sphenoid wing. So again, a nice example of how MRI and CT are complementary in characterizing skull-base pathology. In this 71-year-old female with nausea and vision changes, we can see that there is a mass eroding the clivus, extending to the floor of the sella turcica and extending into the sphenoid sinus. And the coronal plane, we can see that the mass is not easily distinguished from the overlying adenohypophysis. And this is a surgically proven pituitary macroadenoma. Macroadenomas are benign tumors that arise within the pituitary gland, but they can be quite invasive and be quite large. And this is a nice example of an invasive pituitary macroadenoma with a primarily infracellular pattern of extension to invade the clivus and sphenoid sinus. They can also invade the cavernous sinus, and when very invasive, can extend to the nasopharynx. In the 68-year-old male presenting with headache and diplopia, this is an example of a large, aggressive, erosive mass centered within the clivus with solid enhancement. In the axial plane, we can see that the mass is relatively T2 intermediate, so not typical in its appearance for chordoma, because initially we might think that, but this is far more T2 intermediate than what is typically seen with chordoma. We can see the mass extends into the pterygopalatine fossa and solidly enhances, and this is a surgically proven nasopharyngeal carcinoma. Nasopharyngeal carcinoma can be keratinizing or non-keratinizing, and a substantial portion of non-keratinizing nasopharynx cancers are related to Epstein-Barr virus. It has a propensity for perineural spread of tumor, direct extension into the central skull base, as we see in this case, and metastasis to cervical lymph nodes, particularly levels 2 and 5 lymph nodes, as well as retropharyngeal lymph nodes. The last subject I would like to briefly touch base on is numerous skull base foramina that extend through the sphenoid. Remember that you can have pathology affecting the skull base foramina of the sphenoid. Notice in this example that there is abnormal enlargement of the left Vidian canal and the left foramen rotundum, with erosive changes involving the left pterygoid process. Additionally, the ipsilateral left foramen ovale is markedly widened, and this is an example of surgically proven perineural tumor spread from squamous cell carcinoma. In the second case, we have a partially cystic and solid mass along the course of the right fifth nerve that is causing remodeling of portions of the right greater sphenoid wing and body of the sphenoid, and marked widening of the right foramen ovale. And this is a nice example of a fifth cranial nerve schwannoma. So this brings us to the end of our talk on the central skull base. Remember, the skull base is a platform at the bottom of the cranium, and it supports the rest of the brain. It serves as the entrance and exit for major neurovascular structures. The sphenoid bone is the main osseous component of the central skull base. There are many benign lesions and variants of the central skull base related to its development. For that reason, it's important to have a basic understanding of the embryology of the skull base. CT and MRI are complementary in evaluating central skull base lesions. So if you have an incidental finding seen in the central skull base, particularly on MRI, make sure that you correlate with the CT before making final decisions about further management. Lesions centered in the central skull base can extend to the adjacent intracranial and extracranial compartments. And similarly, lesions within the adjacent extracranial and intracranial compartment can involve the central skull base. I'd like to thank Dr. Fatterpaker again for inviting me to give this talk, and you can email me with any questions. Thank you.